Hello, everyone. Welcome to the Aortic Summit by Genentech and Mountains Foundation. My topic today is the current status of genetic testing in aortic dissection patients. So in 2010, there was already a debate between Diana Mitowitz and John Lafteriadis regarding doing the genetic test in aortic aneurysm or not. It was very interesting to read the paper. And the conclusion is probably, yeah, we should do the genetic testing for aortic aneurysm selected patients. When I read John's paper, I found this picture was very interesting. In 1850, the physicians were treating the aortic aneurysm with electric shocking. They put the electrical trocar into the aneurysm, then turn on the switch, bzzz, and shock the aneurysm. They thought this can promote the thrombosis of the aortic aneurysm and stabilize the aneurysm. 150 years, 170 years now after, we can see the difference between the treatment before and now. Current practice for aortic dissection, do we do genetic tests for aortic patients? Most of the dissections taken care of by cardiac surgeons, vascular surgeons, and when they're stable, we may follow up with cardiologists for blood pressure control. If you ask all the doctors, clinicians, do you guys recommend any genetic test for patients with aortic dissection? I think majority of clinicians do not. So there is not too much data to support the practice and refer patients to genetic tests. We then did a study. It's a very interesting study, and we collected the patients with aortic dissection and a DNA sample, and we also have a large pool of control, which had no dissections. The patient come to the University of Michigan, and we matched them, and the 235 patients with dissection, and 5 patients with rupture, and 258 patients as normal control. Very interesting, we found that 26 patients had a pathogenic mutation, which is current known pathogenic mutation. The mutations are in 6 genes, majority in fibrin-1 ex-Marfan's patient, and a few patients in SMART3, TGF-beta receptor 2, PRKG1, NOX, and collagen 3A1. In the control group, there was no pathogenic variants found. It's very interesting. You can see 26 out of 240 cases, more than 10% of patients had positive finding of pathogenic genetic mutations or variants. So then we analyze those patients with and without pathogenic variants. We find out several things put the patient in high risk. Number one, family history. If they have family history of aortic dissection or rupture, especially mother, sibling, or child, they will have a high risk of positive pathogenic finding. And if another thing is they don't have a history of hypertension or smoking history, and they are not younger. Look at them, and they are 41 years old in the pathogenic group and 57 years old in the non-pathogenic group. So the multivariable logistical regression showed the odds ratio of pathogenic finding in patients with dissection. If they are younger than 50, odds ratio is 5. If they don't have hypertension, and odds ratio is 5.5, family history mother 5.5, and sibling and children is all close to 5 and 6. So look at those numbers here. It tells us when a patient is young, less than 50 years old, they don't have family history, don't have a history of hypertension, but they do have family history. They're really at high risk to carry a pathogenic variant. So we made our recommendation based on this finding, and this published in Circulation, Precision Medicine, and Genetics. So when we have a patient who has aortic dissection type A or type B, and they are young, less than 50 years old, have family history with aortic dissection, and no history of hypertension, we strongly recommend genetic sequencing or genetic testing of the patient. If the patient carries the pathogenic variant, and the whole family should be sequenced. And if we find any family with this pathogenic variant, and those family members should be closely watched, and the operation, the prophylactic operation, should be performed earlier. Then we followed all those patients with the pathogenic variant, and we had actually 5 more patients to the cohort, and see how do they progress after the first initial event of aortic dissection. Do they get more operations? Do they die earlier? All these things. So we found out in the patient with the pathogenic variant, they all had a significantly higher chance of multiple operations, 1 or 2 or 3 reinterventions. And this is very interesting. Our statistician did a very sophisticated analysis. Look at this graph. This is a mean cumulative reintervention of 2 groups. If a patient has a pathogenic variant, 10 years, they are about 1 patient. So at least 1 reintervention happened to each patient. If patients do not have pathogenic variants, even they have dissection, is 0.5 reoperations per patient at 10 years. Then we'll look down which part of the aorta, native aorta, left in the patient caused the reoperation. We found out aortic root is the key player. Almost 100% patients after 10, 12 years will have their aortic root replaced if they didn't have their aortic root replaced at the initial operation for aortic dissection. For aortic arch, a little bit higher chance, but not significant. Thoracic, descending thoracic aorta, no difference. Abdominal aorta, no difference of reintervention between the pathogenic group and the benign or normal variant group. So this is a summary about a follow-up of progression of the aorta. Only the aortic root will need reintervention, significantly higher reintervention rate, about 10 times higher in the pathogenic group, which means the patient with the pathogenic variant. The other part, arch, descending, and abdominal, they don't have any difference between the pathogenic group and the benign or normal group. All patients had the aortic dissection. So this is Cox model confirmed that the hazard ratio of pathogenic variants to have a root reoperation is 13 times higher. The survival actually is not different between those 2 groups, pathogenic group and non-pathogenic group, or normal benign group. So based on our study, and I think take-home message is, when patients have an aortic dissection, that's a high chance to have a pathogenic variant. It's about 10 to 11%, much higher in the general population. Number 2, in the high-risk population, patients younger than 50 years old with positive family history of aortic disease, including dissecting aneurysm or rupture, but no history of hypertension, they are much higher risk to have pathogenic variants. So those patients should be referred to a genetic counselor to get a genetic test. Number 3, in patients with pathogenic variants, aortic root should be replaced either with the valve-sparing root, a bento procedure, or to replace the root. Otherwise, the patient will come back for sure to have the root replaced. So this study is done by our lab and Christine Wheeler, Dr. Wheeler's lab. You can see our labs on the left and Christine Wheeler's lab on the right. And the middle person is Brooke, who did the majority of the work of the genetic analysis. Christine Wheeler is the middle one with the frame of yellow, and Elizabeth Norton was the right person with the yellow frame, who did the second part study of the progression of the aorta after dissection. Thank you for your attention.